New Year. And as we enter 2025 and start off today with our speaker, Dr. Sherry Tang. Today she'll be talking about a special category of MPGN.
Thank you very much for having me here. This is my first time to give a presentation on glaucoma, and I'm a renal pathologist from China. I worked on this area for around 20 years, and in my lab center, we have more than 1,000 renal biopsy every year. And today I'm going to share a special category of MPGN pattern. It's about a case and the case-based study. And this study was supported by some national foundation from China. And these are my working places with IF. We can detect IF, LM, as well as EM. And those are my colleagues. Okay, then let me to introduce the case. She's a 73-year-old female. She came to the hospital with mild edema and abnormal urinalysis for 4 days in 2023. She had hypertension for 3 years, and the highest blood pressure is up to 180/90. And half a year ago, she got a cerebral infarction. So she took some medicine to control the blood pressure and the blood lipid. And the lab test showed that she had a nephrotic syndrome with slightly increased serum creatinine. But the other second cause detection, including the monoclonal immunoglobulin, as well as autoimmune disease and malignancy, were all negative. So she did renal biopsy in our center. The immunofluorescence on frozen tissue showed all the immunoglobulins as well as light chains were negative. The complement C1q was negative, but C3, it showed weak staining, especially along the capillary lumen. So C3 is positive. We got 3 cortex with around 20 to 30 glomeruli. And on the low power field, it showed focal fibrosis. In the medium power field, we saw some mesangial expansion, but it's not severe. And some glomeruli showed ischemia. But in some other areas, the mesangial expansion was much more severe. And it started to show the MPGN pattern, membranous proliferative pattern. In Masson staining, some mesangial area showed a nodular expansion pattern. And within some capillaries, we find some immune complex deposits. The silver staining showed some glomeruli has a membranous proliferative pattern with double contour. And within some capillary lumen, there were hyaline thrombi. And in some other capillary lumen, it showed a hypercellularity. The EM was very similar with LM. The morphological pattern showed nodular expansion. And within some capillaries, we saw some macrophages with enlarged huge abundance of lysosomes, obstructed the whole capillary lumen. And in some other areas, it showed some dense deposits within the obstructed capillary lumen and surrounded by macrophages. And also in some mesangial area, there were some low dense deposits as well as subendothelial area. But on the high power field, the dense deposits showed a very good substructure with elongated curved fibrils. And in some other areas, it showed a microtubular, very large microtubular structure with swirled fibrils. And in the mesangial area, there were also some dense deposits. And in high power field, it showed the elongated fibrils. So according to the morphological pattern, our patient had immunofluorescence with C3 staining. LM and EM showed mostly MPGN pattern and some area with endocapillary hypercellularity. And there were some intracapillary hyaline thrombi, and most of the dense deposits with substructure. So there were two diagnoses in my mind. Firstly, is the patient C3GN? But before we make a C3GN diagnosis, we need to do paraffin embedded, uses paraffin embedded tissue to do the pranase digestion, because some of the immunoglobulins could be masked on the frozen tissue. And I really like this idiom by